the 1787 room is not available during that time, so make sure that you check what room you are assigned to go to, because we make sure that we have specifically bring 2 pencils and a calculator with you, and be prepared. Be prepared to remember that the test format is the same as it was in the first semester. So I know there's a lot of test anxiety out there. So the other thing that I want to just say about this is that it is the 3rd week of school. It is winter. It is really awful outside. It's a depressing time of year. People get really stressed out the first few weeks back to school because everything's happening. Everybody's trying to get back into the routine. Plus it's winter. So really, if you have a meltdown over the weekend, give yourself permission to have a meltdown, okay? It's okay. And then get back up on the horse and get going, because sometimes that's what you have to do. And I know I worked with students a lot for many years, and I have seen it happen time and time again this time of year. I promise, spring is just around the corner, and you're all going to feel better. And I want you to think about this. Technically, there's only 14 weeks in the semester. We're already through 3 of them. You have 2 full weeks off. That means you really only have 9 weeks left in this semester when you think about it, okay? So that's a positive way to remind yourself of things. And in March, we'll turn the clocks ahead, and you guys can see it's already getting lighter later out, and we are ending January soon. February is right around the corner. So just trying to give you some positive thoughts to hang on to. I know it's really hard. At break, when we take a little break today, if you are here, if you could just come down and touch base with me for a few seconds. Alice Casano, John Zamperini, Stephanie Collins, Jennifer Katsuba, Mary Berger, Jessica Hughes, Elizabeth LaPointe, Brooke, where are you? Are you here, Brooke? Let's go. No? I want to make sure I'm saying the last name right. I know Jillian's probably not here. The roads are bad. Okay. Alyssa, Haley Armstrong, Olivia Bartlett, Brad Stewart, Rachel Douglas, Nava, Alexis Locke. Okay? Just come quick, talk to me at break. All right, so we're going to talk about, do you have any questions for me first? Any questions? None? Okay, great. All right, so first, I'll try to get through this lecture. You know me, though, I always talk, right? So I'll try to get through this quickly so that you're not here the whole time, but I can't promise, because there's a lot of material. So we're going to talk about the care of patients with stomach disorders to start with, chapter 58. One of the things that I always really encourage students to do is that whenever you're reviewing any system, it's always really helpful if you can go back and look at the anatomy and physiology of the system. And so some of the chapters previous to the reading, like I think 57 covers the digestive system, it helps put things in context. So going forward for the rest of the semester, when we're looking at different systems, even though it's not a required reading or a required chapter, I highly recommend, because it might help you put things in perspective. So this is a picture of a bleeding ulcer on the gastric mucosa right here. You guys can see this. I know the colors aren't so great here, but normally the gastric mucosa is this nice, beautiful, pale, smooth pink color. We don't want to see any interruptions on it, and this is right here. This is definitely gastric ulcer, and I can guarantee you that is probably very painful. So I want to be very clear that just in case you're getting this mixed up in your head, I don't know if you are or not, just to be clear, we're talking about gastritis, not GERD. We're going to be talking about peptic ulcer disease, not GERD. Gastroesophageal reflux disease is a whole other topic, okay? So right now we're talking about gastritis. And gastritis, itis means inflammation. So gastritis is inflammation of the gastric mucosa. It can be really erosive. It can cause ulcers or not. We can have acute episodes of gastritis where there is return to normal mucosa within a few days. Just like you cut yourself, you're irritated, it heals up in a few days. The mucosal changes, though, that result from chronic gastritis, though, are significant. And we're going to talk a little bit more about that. Now, interestingly enough, when I first started in nursing years ago, we had no idea that there was this bacterium called H. pylori that caused the problems in the stomach. So the most common cause, believe it or not, of gastritis is a bacterium called H. pylori. And it wasn't really until 1985 that we figured that out. So it hasn't been, well, now I guess that's 30 years, so maybe I'm dating myself a little bit. But it's been 30 years that we've been treating H. pylori with antibiotics. And the other really common cause of gastritis is NSAIDs. So, for example, Aleve, naproxen. Naproxen is a big, big problem in terms of causing problems with gastritis. Motrin, or known as ibuprofen. So people take a lot of that. Again, there's my mantra about over-the-counter drugs, right? They should be behind the counter. A lot of people end up showing up because of abuse of NSAIDs, which can cause gastritis. There are a couple of different types of chronic gastritis. Now, type A gastritis, what ends up happening is the mucosa gets so worn out that people lose what's called their intrinsic factor. So I don't know if you guys remember this from nutrition or anatomy and physiology, but it's your ability to process B12. And so when you lose the ability to do that because of damages to the gastric, to the mucosal lining, when it gets worn down, you end up having a diagnosis of pernicious anemia. And often patients who have pernicious anemia end up needing shots of vitamin 12. So if you have a family history of this, you may be at risk for having type A chronic gastritis. What are some of the other things that you think cause gastritis? Okay.
Eating acidy foods.
Eating acidy, spicy foods. Okay. Yes, definitely. Absolutely. What's our favorite thing to do in the morning?
Coffee.
Coffee, right? So caffeine, chocolate, unfortunately. All those things that we really love can cause gastritis. Also, alcohol, the other thing that can contribute to gastritis is steroids, okay? So that's another thing. When you've got patients on steroids, you want to be thinking, do we need to be giving them some medications for their stomach? So lots of times we'll put patients on, you know, like an H2 antagonist, Zantac or something like that, prophylactically to prevent any problems with the development of gastritis. Also, smoking is another really big cause of gastritis, believe it or not, and radiation therapy. So patients who are sick with cancer, who are undergoing radiation therapy, for whatever reason, and we know stress contributes to this, will develop gastritis. So those patients also will put on a prophylactic regimen of like an H2 antagonist or a proton pump inhibitor to help prevent that.
What about the overuse of antacids?
Yes. So you can have a rebound effect, Moses. So that's a really good point. So sometimes when people have gastritis and they've got all this pain in their stomach, right, they go eat a whole bottle of Tums. And so what ends up happening is they actually, as a result of that, they get this thing called rebound gastritis because the system is just producing more acid as a result of it. And so it's kind of defeating the purpose. So absolutely, good point. All right, so one of the things that we want to talk to patients about, right, is having a really good balanced diet, eating healthy. Again, here it is, avoiding NSAIDs. Don't take naproxen, don't take Motrin. I gotta tell you, I've seen some of the most unbelievable GI bleeds in my nursing career. I used to work in the emergency room. It was one of my favorite places for years. And GI bleeds from naproxen, bad stuff. So really careful use of it. And then there are lab tests that we can do for patients, so when they start to present in the doctor's office with some of the complaints, the signs and symptoms, we can test for the H. pylori, which is what we're going to do, IgG or IgM, anti-H. pylori antibodies. Now, one of the things that we can do is this test called the EGD. Whoops. Back down. And that's used, that is the gold standard for diagnosing. All right, so I asked you guys to take a look at that test, the EGD, and you know, let me just find it. I have it marked, I apologize. Here it is. Okay. All right. So you know, one of the things that that we use is an EGD, and and I had to go to the book because I have to read the word in order to say it. Okay. So it's esophagogastroduodenoscopy. Okay. And one of the things that's really important. Yes, Rebecca. So this is on page 1231 of your book. It's in chapter 58. And there is a little blurb about it that talks about a nursing safety priority, okay? So there's a reason I'm talking to you about this. Pay attention. After we do this, okay, esophagogastroduodenoscopy. And that's a scope that gets inserted down so that we can look at it and we can get little biopsies of the tissue. One of the things, of course, we're going to have IVs in you, and we're going to give you medication to make you kind of not realize what's going on. But one of the things that's really important about this is when they insert this tube, they also numb up your throat with lidocaine. And so when you wake up, you know, from post-operatively, we always talk to you guys about how it's important to think about the ABCs, airway, breathing, and circulation. But in addition to that, with this particular test, the thing that's really important, a really important nursing assessment with this test, is that you want to remember to check for their gag reflex. You want to make sure that their gag reflex is returning before they start to eat or drink any fluids, because they're going to be at risk for aspiration.
Yeah, so my daughter just had this done, we moved it up, and it made her cough, like 24 hours.
Cough, 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 cough.
Yeah.
Because she was irritated and the lubrication, like that really thick lubrication, and so she's just trying to get this mucus out of the back of her throat. And also the inflammation, the irritation from the whole process.
And it was pretty bad, and then cough.
Cough, 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 cough. All right, so that's good to know, actually. All right, so that is the gold standard for diagnosing gastritis. Now, peptic ulcer disease. Okay, so we've got gastritis, right? We've got this inflammation of the mucosal lining. Sometimes it's acute, and it can resolve with treatment of antacids, with treatment of, sometimes we take Maalox or Crohn's, we change our diet, we watch what we're eating, we eliminate our stress, we meditate, we do those kinds of things. There's all kinds of alternative things. And then sometimes what ends up happening is It doesn't get treated. We don't identify the H. pylori. It doesn't, people don't do what they're supposed to do, and they end up with a process called peptic ulcer disease. So peptic ulcer is a mucosal lesion of the stomach or the duodenum. And it occurs when those mucosal defenses become impaired and they're no longer able to protect from the production of pepsin and acid. Hydrochloric acid in the stomach is pretty powerful stuff, okay? So normally the stomach has this nice mucosal lining and it's secreting mucus all the time to protect it. But when you have peptic ulcer disease, you're not going to see that. And there are 3 different kinds of peptic ulcer disease. So gastric ulcers, duodenal ulcers, and what's the difference between gastric ulcers and duodenal ulcers?
Location.
And, absolutely location, and what else? Any idea? The symptoms, right? So lots of times gastric ulcers, and there's a little chart, gastric ulcers will occur, the pain will occur like maybe 30 to 60 minutes after eating. Lots of times duodenal ulcers, people will have eaten and they go to bed and they wake up at 2 or 3 o'clock in the morning. So it's really with this severe pain. So that's the difference, because it's taking a while for the food to get down into the duodenum, and then the acid production increases. So the thing that's important is to do a really good history with your patients, to ask them what the signs and symptoms are, when is that pain occurring, and then again, stress ulcers occur. We actually don't have a really good understanding, I just want to put this out there, of why stress ulcers occur. We do recognize this, and I do want to say this, and this is important to remember. Lots of times when patients go to surgery, we know that because of the body undergoing the stress, just the stress of surgery itself, that patients are going to be at risk for a stress ulcer after the surgery is over, no matter what kind of surgery it is. Whether it's abdominal surgery, whether it's a hip surgery, whether it's shoulder surgery, whatever it is. So prophylactically, again, in the hospital, you're going to see patients put on some kind of H2 antagonist. So very often they're going to get Zantac. You're going to see Zantac IV given prophylactically. So they come out of the operating room. Did I say before? If I said before, I take that back. It's after, okay? So I want to be careful. When you come back out of surgery, you're going to find that you're getting Zantac IV. And patients are going to say, I've never had trouble with my stomach. Why are you giving me this medication? And the reason we're giving you this medication is it's a prophylactic way of preventing a stress ulcer from occurring, because we know patients get stress ulcers. Yes, Bruce?
Is it more from the stress of surgery, or is it from that 14 to 18 to 24-hour window of zero intake?
Of being FPO, you mean?
Yeah.
We don't quite know. I mean, we understand that, yes, the 14, whatever the window time is, and now it's really generally 6 hours that you're FPO. So yes, you've got all that acid that's sitting around. But as soon as we give you anesthesia, we shut all that down. So it's not like it's necessarily sitting or continuing during surgery, but it could be a contributing factor. It definitely could be. So it's also the body's natural inflammatory response to the stomach being shut down by the anesthesia as well. So,
Are those ulcers as a result of the H. pylori that are present in the system, or unrelated but maybe caused by H. pylori?
Yeah, so gastric ulcers and duodenal ulcers, the peptic ulcer disease is a result of the H. pylori. Stress ulcers can also be a result of H. pylori. Some people have more of a genetic tendency to have actually the H. pylori bacterium. There's some theories, I think your book even mentions this, that they think we ingest it when we're children, and it shows up later in life. So all 3 can be caused by H. pylori, but sometimes we don't necessarily know if the stress ulcer is directly caused from that, or if there are other contributing factors. And certainly we know when people go to surgery, that is one of the contributing factors there. Yep. Does that answer your question? I'm not sure.
I was just trying to find the culprit.
Okay.
We're looking
H.
at,
pylori.
okay.
It's the culprit, most times. Okay. So this is just showing you kind of the difference between gastric ulcers, duodenal ulcers, and stress ulcers, right? So common risk factors: stress, H. pylori, alcohol can contribute to ulcers, smoking again. I think I've said that a couple of times. You might want to pay attention to that. Stress ulcers, okay? We all have psychological stress. You guys are all students. No wonder you don't all have peptic ulcer disease, right? Cushing's ulcer, brain injury, Curling's ulcer can occur as a result of extensive burns. People who undergo, who have severe burns that are hospitalized for severe burns often will develop stress ulcers. Then duodenal ulcers are the most common. Pain, again, is usually 2 to 3 hours after meals. And food may actually decrease the pain with duodenal ulcers. So you can see I'm kind of moving around this clock here. Gastric ulcers, you're going to see weight loss. With duodenal ulcers, you may not see weight loss. And again, the gastric ulcer pain is a half an hour to an hour after meals. Sometimes you'll see vomiting, and eating may actually increase the pain. Right. So this is just a picture of peptic and duodenal ulcers in some of the most common sites, so that you can just get a visualization of where they are. So here is a very common site of the duodenal ulcer right below the pyloric sphincter. There's more acid production that's moving through in that area. And then also here on the lesser curvature, because of where the acid also is produced in the stomach. This is showing you a benign gastric ulcer right here, okay? And then this right here is actually a duodenal ulceration. Now this is the esophagus going down. This is a scope looking down. These are the nice ridges. And actually, I don't know if you've ever seen, there's a movie of mine that I play in an A&P class sometimes that I love it. It's my favorite one. It does a really nice job of showing the peristalsis and the movement of the esophagus. And so you can see right here, this is bad, right? This is really bad right here. So, one of the things about this ulcer is that there's no evidence to suggest malignancy. That's one of the things that we got to pay attention to with these ulcers. This one also has a background of duodenitis. So I don't know if you guys can see this or not, but on this slide right here in this area, it's almost like it's chapped. Do you know what I mean? It's raw, it's irritated. So there's this like patchy area of what we refer to as duodenitis. All right, so the complications of hemorrhage, when we think about it, when patients show up, this is really important. Most times, complications of ulcers that we're going to see in the emergency room is GI bleeding, okay? And when people have GI bleeding, it can be really difficult sometimes to stop it. And one of the things that you want to be thinking about, again, ABCs, but I'm going to tell you this is another priority. It's really important. You want to get a line in. You've got to get a large bore, 18 gauge usually is what we put. You want to try to even get 2 lines. So I remember working in an emergency room, when we had patients show up and they were complaining of pain and they had hematoemesis, which is what? Bloody emesis, right? Or coffee ground emesis sometimes. They'll have coffee ground. And the reason it's coffee ground is because it's the acid that actually kind of eats up the blood, and it makes it that coffee. It's literally coffee ground when they're throwing up, okay? When I had people like that showing up in the emergency room, I knew it was time to get a line in, because we were going to have to be giving them fluids and managing that. Sometimes you'll have patients with blood in their stool, so it'll be on the other end, we'll see. And then sometimes what can end up happening is patients can develop peritonitis, and I've got a little slide on that. And let me show you that next. And then also the other complication is obstruction. So these are all the things that we want to be thinking about. So how do we assess it? What are the clinical manifestations? How do we determine which one it is? Okay. So because of the anatomy and physiology of the body, if it is a gastric ulcer, we can usually tell that because they will have pain to the left of the midline, just because of where the anatomy and physiology is. If it's duodenal, they'll have pain to the right of the midline. And then again, we're going to talk to them about the assessment, the pain, when it comes on. Dyspepsia is referred to as indigestion. They'll often complain of that. When you get patients in that are having stomach problems, another thing that you really want to check for right away is orthostatic hypotension. Because if you are bleeding, your blood pressure is going to drop because you don't have enough circulating blood volume to keep your blood pressure up. So you're definitely going to check for orthostatic hypotension. The other thing that you're going to check for is bowel sounds. And one of the things that I just want to say about this is you can have a patient who has an obstruction that's going on as a result of the ulcers or the GI, and they will have these screaming, high-pitched bowel sounds, often in one quadrant, which is up above where the obstruction is. And then you will often not hear them in the other three quadrants. So don't think that because you're hearing these screaming, high-pitched bowel sounds that a patient doesn't have an obstruction, because 9 times out of 10 when they have those kinds of bowel sounds, they do have an obstruction. You're also going to check for rigidity and rebound tenderness, because when you get into a problem with obstruction, obviously things back up in the abdomen, it gets very firm, patients get very bloated, and they have this rebound tenderness. So these are some of the different things that you're going to do in terms of assessment. You're also going to be thinking about what else do I want to say? I think I repeated this. This looks like a repeated slide. I thought that to myself again last night. But I just want to reinforce this, okay? Continued erosion can result in this, what happens is it tears down the mucosal lining, but it can also result in scarring and a thickening of the wall sometimes. And you can end up with peritonitis, pyloric obstruction. Again, I just want to reinforce that hemorrhage is the most serious complication, checking orthostatic blood pressure, and evaluating for dehydration. Again, looking for that coffee ground material, and also assessing sharp pain and a firm abdomen. Okay, labs again. I think I've said this a couple of times, right? H. pylori, that's what we're going to check for. There is another test that we can do. We can do an imaging scan. We can take patients to the nuclear medicine area, and we can do this nuclear medicine scan and do an image, take a look at the stomach. But the best way, again, is that gold standard. It's the EGP. The best way is to get inside and really look at the lining of the stomach. because imaging with nuclear medicine scans, as good as they are, it's still not as good as having a real picture of the actual lining of the mucosa. Again, I think I've said this a million times, right? Watch the over-the-counter medications. So I said NSAIDs, but I forgot to mention aspirin, okay? And in particular, the older generation of folks are really big into using aspirin. And aspirin can do some really nasty things too in terms of causing GI bleed. And I see some of you shaking your heads, so I think you've probably seen it, right? So the thing that's important about this is we used to, the primary treatment for arthritis years ago used to be aspirin, like really intense high doses of aspirin. And here's the other thing. You hear people, you see on the news and the media all the time advertisements for what? Why do you want to take an aspirin a day? Right, so people get these ideas in their head that if you take a couple of aspirin a day, that's really going to help prevent a heart attack, okay? So you really need to ask good questions about are they taking it. Really encourage people not to eat right before they're going to bed. You want to make sure that you don't eat a full meal at least 2 hours before you lay down at night. You want to give the stomach time to digest some of that food. That will help with the acid problems that can occur from eating heavy meals at night right before bed. And the other thing is you want to ask them if they're having trouble sleeping. Like I said, if they've got a duodenal ulcer, it can often wake them up like 2 or 3 hours after they lay down at night. Here's some of the drug therapies that we're going to use.
Is there a nursing intervention for nuclear medicine?
No prep needed. That's the nursing intervention, right? That was on your study guide, right? No prep. That's the key. It's good because we can pay patients in right away. If you do an EGD, it's going to be MPO for a period of time before you can do it. So, all right. So drug therapies. Mylanta and Maalox. Here it is again. I talk to you guys all the time about lab values. Kidney function, all right, is really important to look at when patients are taking Mylanta and Maalox because it can cause problems. And I just want to give you the page number in the book. And you guys have probably started reading a lot of this, but you know, one of the things that this talks about on 1223 are the different examples of drug therapy. And so we talk about magnesium hydroxide, Maalox and Mylanta are what we are referring to. If patients have a history of renal disease, we do not want to give it to them. And the other thing that is kind of interesting, I don't know if you've ever noticed this or not, but some antacids have a really high sodium content. And so people with heart disease really need to be paying attention to this and not taking